Welcome to Module 8, Integrating Behavioral Health and Healthcare. Currently, there's an enormous problem across both child and adult mental health services in that the majority of individuals who need mental health services never receive treatment. So they either don't access services altogether, or if they do engage in treatment, they end up dropping out prematurely before they've received a suitable therapeutic dosage. We also know that services are very siloed, so there's very little communication across different service systems. Um, and there have been some efforts to move detection and outreach into health settings. So, for example, screening pregnant and postpartum women for depression. But there are problems inherent in those models also, which we'll talk about. And the detection of mental health issues and addressing them is usually low. We also know that the mental health service system is beset by challenges with respect to workforce shortages and particularly psychiatrists. So there's very frightening data out there that suggests that the number of psychiatrists per geographic area is not suitable to address need. Beyond that, there was a recent report in New York that looked at the 5 boroughs of New York City, and in 3 of those boroughs, they only had enough treatment capacity to serve 4% of all the children who were evidencing early symptoms, so birth to 4 years of age. So that suggests that there's multiple problems in terms of the provision of mental health care as well as access. That is affecting most individuals who have an identified mental health need. So there are several emerging programs and practice models that we'll talk about to address these issues. The first, co-located models, so co-locating mental health and maybe behavioral health services in the same setting, or coming up with a streamlined care delivery system in which there's what we call a warm handoff. So if someone's identified in the health system as having a mental health need, that health system also facilitates active engagement in mental health services instead of just giving a passive referral. The second are innovative cross-disciplinary approaches to detection and outreach, so using lay personnel and other non-mental health professionals to detect and facilitate engagement and treatment. And treatment of mental health problems by an alternative workforce. So actually the provision of mental health services as well as case management by a non-mental health workforce. So co-located models are emerging across the country. There are many different types of co-location. There is a co-location model in which mental health services are firmly embedded within that health setting. Also, there are types of co-located models in which there are mental health professionals, maybe not a clinic, but mental health professionals that facilitate detection and outreach to maybe a partnering mental health service in the community, or one that is part of their agency but not geographically located in the same space. And co-located models come out of the theory, which has been amply supported, that individuals who have mental health problems that are untreated go on to also experience considerable health problems. So there's, if you remember from the module on depression, there's actually a high correlation between depression and poor health, including cardiovascular health, diabetes, stroke, and some types of cancer. So instead of looking at mental health and physical health as 2 separate entities or composition of an individual, we're starting to look at the integration of those pieces of a person. And by treating both and identifying untreated mental health need, the hope is that health outcomes also improve. Co-located models can be used for prevention. So the Institute of Medicine, I believe in 2001, came up with a categorical system for prevention programs. And they include universal prevention programs, which are prophylactically targeting a population who may not exhibit any kind of need, but the mindset is if you provide these supports, it will prevent the onset of symptoms or difficulties in particular areas. There's also selective prevention programs where, based upon a risk factor, you would provide services, even if the individual wasn't necessarily symptomatic. And then third are the actual interventions, prevention models for individuals who are symptomatic. So co-located models that involve that are prevention focused can target universal, selective, or intervention prevention. And there's an example here. If you look at the, if you click on the SAMHSA website link that I just provided on the slide, that gives you an idea about ESPERT, which is a prevention model for alcohol drug use. And as I mentioned before, co-location may occur or may include all services being provided in one location, referrals off-site, or a combination of the two. So this is an example of a grant I worked on in which we developed a decision tree for kids who are identified in primary care as needing further evaluation for potential emotional behavioral difficulties. So if you look at the top, the first box, our target was children between the ages of 5 and 18 who presented at primary care. And what's important to point out here is that they could be presenting just for their well child visit. It didn't have to be necessarily for a mental health consult. And with that in mind, however, do know that for certain diagnoses such as ADHD, behavior problems, usually the primary point of detection is in the primary care setting. So caregivers are likely to call their pediatricians and say, hey, can you evaluate my son? This is going on. I'd like to bring him in. So the hope is that this kind of model would capture those kids who might not necessarily touch the mental health service system. So in any event, the caregiver would have to give consent for the pediatrician to screen the individual. There are other types of screening. We use the PSC, so the Pediatric Symptom Checklist, and there's certain versions of that. There's a pediatrician administered version, there's self-report, so the caregiver completes the PSC. In this case, the guardian or the caregiver would complete the PSC. And based upon how they scored, and you can Google the PSC because it's a really interesting checklist. Some of the items include feeling hopeless, having trouble sleeping, worrying a lot, feeling that you're bad, taking unnecessary risks, having trouble with the teacher, and they would indicate whether this was never a problem, sometimes a problem, or often a problem. Now, it's interesting to note that a self-report has been criticized for being very subjective. So a caregiver might rate the child one way. The child completing this might rate themselves a separate way. And there's actually some literature that suggests when you're asking two parents to complete a given measure that even parents will tend to rate their children's emotional behavioral difficulties differently. So it's always important when you're asking someone to complete a self-report measure that you consider the source and that there will likely be bias or there is some kind of variability in terms of responses across respondents. Anyway, so if you look to the left of this, if the individual scores negative, so if they don't meet criteria, and the clinical cutoff, so you're tallying those sometimes and often, if it's less than 27, for children who are between 6 and 18 years of age, or less than 23 for children under 6, you would just re-administer the PSC at every 3 months or at their next primary care visit. However, if they meet criteria, so if they score above a 27 or a 23, depending on age, then you make a decision as to how you're going to manage that potential mental health risk. And there's 3 ways to do it. The child might be managed in primary care. So the pediatrician or a social worker in that setting might then conduct a comprehensive assessment and reassess the PSC monthly. Or they might refer the child to a provider off-site, or they might refer, if they have an insight setting, clinic or individual, they might refer them to that setting or that referral. So this is just an example of how you might go about integrating primary and behavioral health, and that there are many, depending on the setting, there are different ways in which you can manage mental health need, making sure that it is addressed in a timely manner. Also, it's important to consider feasibility here in terms of, do you have someone on site? And knowing that if you refer off site, while it's helpful, it's better than nothing. The likelihood of that individual actually attending treatment in a different site is lower than if you had someone actually in the same setting. So you know what, once you're done with your appointment, can you move on to the 5th floor where there's so-and-so? So I've included several studies and meta-analyses and randomized controlled trials on collaborative care models. Do keep in mind that there is fair variability across models, and part of it is dependent on the infrastructure of the organization. As I mentioned in the last slide, it might not be feasible to refer on site. There may not be anyone, or problems that I've had in that prior study that I just went over the decision tree for was that they were at capacity internally. So the only option after a very short while was to refer outside, or for the pediatrician to manage and re-administer the PSC on a monthly basis. So that's something to consider, that the standardization of these collaborative care models would be helpful in terms of truly determining their impact. But I want to draw your attention to the impact study. That's one of the readings that you have by Unitzer, and it was conducted across 18 primary care clinics from 8 healthcare organizations in 5 states. So that's a huge study. It's a longitudinal study, which means they collected data over time, and that is also a very costly enterprise. So it's something to keep in mind, that this is a very important study because it's unique in its longitudinal focus and just the number of clinics and organizations and states. It was for late life depression, and that's also something to keep in mind. And there were 2 conditions: the impact intervention versus usual care. So again, just a massive number of individuals, over 1,800, who were 60 years of age or older. And the impact intervention was, so the active intervention arm was access to a depression care manager for up to a year. And that care manager was supervised by an interdisciplinary team of a psychiatrist and a primary care expert. And they provided education about depression and treatment, care management, and support of antidepressant use, as well as brief psychotherapy. The treatment type that the individual received was determined by an algorithm. So based upon a certain, how they scored and other criteria, they were allotted to the intervention, what type of treatment they would get within the intervention arm. So it could be antidepressants, could be psychotherapy, could be both. And the comparison arm was usual care. And so that's services they would normally receive in a primary care setting. So, what they found was that compared with usual care, individuals in the impact intervention had significantly greater rates of higher satisfaction with treatment. They attended more sessions, and their depression improved significantly. Before we move on to innovative detection and outreach methods, I want to also draw your attention to the article that you have in your readings by Lewandowski. And what we did there, and that was a project we worked on for several years, is we went through the literature about the evidence behind the management of adolescent depression in primary care and created a decision tree based upon how the individual scored on a measure. So whether they would receive supportive counseling, medication, treatment, a combination of that, and reassessment. And what was notable about that is that many of the decision points that were being recommended by guidelines, the pediatric guidelines, were not supported through the evidence. Not to mean that they shouldn't be administered, but that there was no evidence behind them. So clinically, for example, you would think to conduct a comprehensive assessment is the correct course of action if the child or adolescent meets criteria for potential depression. And there was very little evidence behind the provision of a comprehensive assessment. So what does that mean? It means that even though there may not be evidence behind some of the clinical decision making that we make in terms of management of mental health conditions, it makes sense. Your clinical expertise would dictate that it makes sense to conduct a full, a comprehensive assessment. So this is in the evidence-based practitioner model where your clinical wisdom comes into play. So let's move on to innovative detection and outreach methods. We know that very few individuals will access mental health services, and that if their child or as an adult, if they are in need of treatment or they have a mental health condition, their first choice isn't to call a mental health facility, usually. So we lose the opportunity to detect and to provide treatment to individuals who may need it but never cross the threshold of a mental health agency. So because of that, within the literature, there's been a growing emphasis upon upon screening and detection models in naturalistic settings. So settings that the individual is likely to inhabit based upon maybe their child, or actually Schwartz did a study a few years ago about the administration of a therapeutic intervention, interpersonal psychotherapy, in a supermarket setting. So people were shopping, there was childcare provided, they were screened for depression, and then they were enrolled and received IPT in the supermarket. So I'm going to talk about one model. This is a project I worked on a few years ago to detect maternal depression. So from Module 5, we talked about how there are certain groups that are disproportionately at risk for depression. Female caregivers being one of those groups, particularly if they're impacted by poverty. A recent epidemiologic survey found that over 8,000 women, approximately 10% of female caregivers who were raising a child 18 years of age or younger met criteria for major depressive disorder, and that prevalence rate was twice as high as the prevalence of depression across the entire sample of women. We also know a recent meta-analysis came out that looked at depression amongst women who were impacted by poverty, and the rates of depression were something like 23%. So almost 1 in 4 women, mothers or female caregivers, met criteria for depression. Despite this, very few mothers or female caregivers engage in mental health services for their depression. The research is quite clear that there are several reasons why female caregivers are unlikely to seek services for depression. The first is that there have been tremendous strides in prenatal care. So, screening of pregnant women and women who are immediately postpartum is occurring with greater frequency. It's happening in OB-GYN clinics and pediatric offices. However, beyond the antepartum period, so outside of 1 year, these models are relatively rare. And in part, the movement towards detection of depression during pregnancy and postpartum is driven by several factors. One, that these two periods in an individual's life are more likely to put a woman who has risk factors for depression at risk for a depressive episode. So that's a first reason for that. Secondarily, we know that depression during pregnancy and the postpartum period interferes or can adversely affect the infant, so birth, delivery, and infant development. So there's been a huge movement by the American Academy of Pediatrics and the OB-GYNs to push for screening and detection in these settings. We also know that there are significant barriers to access from the agency themselves. So as I mentioned a few slides ago, there are significant workforce shortages and wait lists for services that impede access. A recent article I worked on with a colleague at NYU found that when we surveyed over, I believe it was, we looked at 27 agencies and an equal number of mental health providers who are in private practice, who identified their geographic location of service provision as East Harlem. When we asked them, do you provide treatment for depression for women who are mothers? What is your sliding scale? What is your wait list? Do you offer services in different languages? The number of providers who actually were able to offer services in a reasonable amount of time without a significant wait list at a reasonable cost, so not $100 per session, and in Spanish was very few. So even though you may have mental health providers and agencies situated in a geographic setting that is where a caregiver might be residing, access to those services may not be any easier than if it was an hour away because of these factors. And then third, we know that there are a host of logistical and perceptual barriers to help seeking. And those for caregivers with children who are experiencing a mental health problem include many of the barriers that you'll find across the general population. So cost for services, lack of transportation, but there's also specific obstacles that female caregivers are likely to encounter. So not having childcare, schedule difficulties. So if you have two children and you're trying to attend services for yourself, that can become very difficult. We also know from McKay and Bannon, and that paper was published, I believe, in 2005, that perceptual barriers are actually more impeding than logistical ones. And perceptual barriers include stigma, fears about losing custody of their children, mistrust of the mental health system. So those factors actually become more impeding and are likely to dissuade moms and female caregivers with children from seeking services for themselves. As I mentioned earlier, the American Academy of Pediatrics and the American College of Obstetrics and Gynecologists are really the front runners in these screening and detection models. Women are likely to attend their OB-GYN and pediatric appointments for themselves and their children. And within these settings, there are a range of professionals, and they may not have a mental health background, but they adequately provide screening for depression and outreach to services. as I mentioned also, it's not as common. So these models are not as common amongst mothers who go beyond the antepartum period, so beyond 1 year. So female caregivers of older children frequently will fall through the cracks. Additionally, in these settings, there have been a set of studies by Chaldron and others who suggest that OB-GYN providers, for example, don't feel comfortable in all cases screening for depression, partly because they don't know what to do with it once they're diagnosed or the mother's in need. So one study I worked on, which is pretty ancient, by Smith, I believe it was in, gosh, it can't be 1994. Wow, am I old? I think it was 2004. I'm dating myself here. But we screened mothers for depression during pregnancy and the postpartum period at 4 OB-GYN clinics located in New Haven. And what we found was a significant number of new moms or soon-to-be moms who had mental health problems, including depression, anxiety, and trauma, were not identified through the OB-GYN clinic. So they missed a lot, but in addition, there were significant barriers to screening and detection. So OB-GYN providers said they didn't feel comfortable, they weren't trained adequately to address mental health, they didn't have the time to do it. There was not a way to be compensated for that level of investigation into their mental health, and they didn't know what to do with it. So all of these present barriers to detection. In 2011, I developed a screening, education, and empowerment model. Actually, 2013 is when it was published, so that's why it shows that it's 2 years later than what I just said. And this model was intended to be delivered by lay personnel, so, and we'll get into that in a moment, but what it involved was a way in which anyone with some training and supervision could screen for depression, provide education about depression and treatment, and make an active referral to services. So using a network guide of providers, sit with that caregiver and walk them through making an appointment, what they'll need for that appointment, and then problem solving difficulties that might occur during treatment. So for example, a common concern we would hear from female caregivers is, I don't want to take medication. Okay, well, instead of dropping out of services, let's walk through how you could discuss that with the mental health professional in a way where you're voicing your concern and you're having a dialogue. You have a reading on this, so I'm not going to go in too much detail, but all of these strategies were chosen because they are, there's evidence for them in the literature that they provide, they can be delivered by a lay workforce, so a paraprofessional workforce, and that they are effective strategies for detecting depression and reducing barriers to help seeking. So when I mention lay personnel, what I'm referring to are peers or parent advocates. And in New York State, they have probably one of the most robust cadre of parent advocates and organizations. And what parent advocates do is they are trained and have to go through a fairly rigorous training protocol in order to provide support, excuse me, provide support, education, skill building, advocacy, and active linkages to services for caregivers of children with mental health needs. So peers in New York State are caregivers who themselves have raised a child with mental health needs, and they have experience navigating the mental health service system. And the utilization of peers is driven theoretically by the premise that if you have that lived experience of being a caregiver of a child with mental health needs, facilitates trust, deepens the alliance quicker than with a traditional mental health professional, and conveys a sense of trustworthiness, and that they also have reduced perceptual barriers to help seeking in the literature. So this is referred to as task shifting. And task shifting has been used across the world, actually. There's a set of studies by Bolton about training community members to deliver interpersonal psychotherapy in Uganda. And there are 3 components to it. So you would modify the intervention or the approach to be in keeping with the skill set of that lay workforce. You would provide training and then consistent supervision by mental health providers. Now, by no means is this restricted to lay personnel, and you have reading about how dentists, and not a reading about this, but emerging models in which hairdressers have been trained to identify domestic violence. It also includes primary care providers detecting and treating depression, which again I referred to previously. So task shifting really involves a systematic way in which you can train a non-mental health workforce to identify and facilitate, or identify mental health need and facilitate engagement in services. The link provided here is a TED Talk by Vikram Patel, and in terms of access in the United States, we've talked about workforce shortages, we've talked about wait lists for services. Worldwide and in developing countries, close to 90% of individuals with mental health needs do not receive them because mental health care just is not available. So Patel outlines a very interesting and innovative way to help individuals with identified mental health needs that addresses workforce shortages, and it's talking about training community members or community workers to deliver mental health interventions. I also want to add here that this is, again, was done in Uganda. There are efforts to do this worldwide. There are pros and cons to this approach, even with the provision of ongoing supervision. The intervention in and of itself can become diluted, and that's what they found in the Bolton study. However, it actually became a very enhanced model and relevant to the community needs. So when they went back and they assessed fidelity, they found that not only were they addressing interpersonal psychotherapy, these community workers or lay persons, but they also included HIV interventions and supportive components. So that just draws the attention to the debate that do you need to deliver an intervention in exactly the same format with exactly the same components in order for it to be effective.
I want you to imagine this for a moment. 2 men, Rahul and Rajiv, living in the same neighborhood, from the same educational background, similar occupation, and they both turn up at their local accident emergency complaining of acute chest pain. Rahul is offered a cardiac procedure, but Rajiv is sent home. What might explain the difference in the experience of these 2 nearly identical men? Rajiv suffers from a mental illness. The difference in the quality of medical care received by people with mental illness is one of the reasons why they live shorter lives than people without mental illness. Even in the best resourced countries in the world, this life expectancy gap is as much as 20 years. In the developing countries of the world, this gap is even larger. But of course, mental illnesses can kill in more direct ways as well. The most obvious example is suicide. It might surprise some of you here, as it did me when I discovered that suicide is at the top of the list of the leading causes of death in young people in all countries of the world, including the poorest countries of the world. But beyond the impact of a health condition on life expectancy, we're also concerned about the quality of life lived. Now, in order for us to examine the overall impact of a health condition, both on life expectancy as well as on the quality of life lived, we need to use a metric called the DALY, which stands for a Disability-Adjusted Life Year. Now, when we do that, we discover some startling things about mental illness from a global perspective. We discover that, for example, mental illnesses are amongst the leading causes of disability around the world. Depression, for example, is the third leading cause of disability, alongside conditions such as diarrhea and pneumonia in children. When you put all the mental illnesses together, they account for roughly 15% of the total global burden of disease. Indeed, mental illnesses are also very damaging to people's lives. But beyond just the burden of disease, let us consider the absolute numbers. The World Health Organization estimates that there are nearly 400 to 500 million people living on our tiny planet who are affected by a mental illness. Now, some of you here look a bit astonished by that number. But consider for a moment the incredible diversity of mental illnesses, from autism and intellectual disability in childhood, through to depression, anxiety, substance misuse and psychosis in adulthood, all the way through to dementia and old age. And I'm pretty sure that each and every one of us present here today can think of at least one person who is affected by a mental illness in our most intimate social networks. I see some nodding heads there. But beyond the staggering numbers, what's truly important from a global health point of view, what's truly worrying from a global health point of view, is that the vast majority of these affected individuals do not receive the care that we know can transform their lives. And remember, we do have robust evidence that a range of interventions, medicines, psychological interventions, and social interventions can make a vast difference. And yet, even in the best resourced countries, for example, here in Europe, roughly 50% of affected people don't receive these interventions. In the sorts of countries I work in, that so-called treatment gap approaches an astonishing 90%. It isn't surprising then that if you should speak to anyone affected by a mental illness, the chances are that you will hear stories of hidden suffering, shame, and discrimination in nearly every sector of their lives. But perhaps most heartbreaking of all are the stories of the abuse of even the most basic human rights, such as the young woman shown in this image here, that are played out every day. Sadly, even in the very institutions that were built to care for people with mental illnesses, the mental hospitals. It's this injustice that has really driven my mission to try and do a little bit to transform the lives of people affected by mental illness. And a particularly critical action that I've focused on is to bridge the gulf between the knowledge we have that can transform lives, the knowledge of effective treatments, and how we actually use that knowledge in the everyday world. And an especially important challenge that I've had to face is the great shortage of mental health professionals, such as psychiatrists and psychologists, particularly in the developing world. Now, I trained in medicine in India, and after that, I chose psychiatry as my specialty, much to the dismay of my mother and all my family members who kind of thought neurosurgery would be a more respectable option for their brilliant son. In any case, I went on, I soldiered on with psychiatry and found myself training in Britain in some of the best hospitals in this country. I was very privileged. I worked in a team of incredibly talented, compassionate, but most importantly, highly trained, specialized mental health professionals. Soon after my training, I found myself working first in Zimbabwe and then in India, and I was confronted by an altogether new reality. This was a reality of a world in which there were almost no mental health professionals at all. In Zimbabwe, for example, there were just about a dozen psychiatrists, most of whom lived and worked in Harare city, leaving only a couple to address the mental health care needs of 9 million people living in the countryside. In India, I found the situation was not a lot better. To give you a perspective, if I had to translate the proportion of psychiatrists in the population that one might see in Britain to India, one might expect roughly 150,000 psychiatrists in India. In reality, take a guess. The actual number is about 3,000, about 2% of that number. It became quickly apparent to me that I couldn't follow the sorts of mental health care models that I had been trained in, one that relied heavily on specialized, expensive mental health professionals to provide mental health care in countries like India and Zimbabwe. I had to think out of the box about some other model of care. It was then that I came across these books. And in these books, I discovered the idea of task shifting in global health. The idea is actually quite simple. The idea is, when you're short of specialized healthcare professionals, use whoever is available in the community, train them to provide a range of healthcare interventions. And in these books, I read inspiring examples, for example, of how ordinary people had been trained to deliver babies, diagnose and treat early pneumonia to great effect. And it struck me that if you could train ordinary people to deliver such complex healthcare interventions, then perhaps they could also do the same with mental health care. Well, today, I'm very pleased to report to you that there have been many experiments in task shifting in mental health care across the developing world over the past decade. And I want to share with you the findings of 3 particular such experiments, all 3 of which focused on depression, the most common of all mental illnesses. In rural Uganda, Paul Bolton and his colleagues, using villagers, demonstrated that they could deliver interpersonal psychotherapy for depression, and using a randomized control design, showed that 90% of the people receiving this intervention recovered, as compared to roughly 40% in the comparison villages. Similarly, using a randomized control trial in rural Pakistan, Atif Rahman and his colleagues showed that lady health visitors, who are community maternal health workers in Pakistan's healthcare system, could deliver cognitive behavior therapy for mothers who were depressed, again showing dramatic differences in the recovery rates. Roughly 75% of mothers recovered, as compared to about 45% in the comparison villages. And in my own trial in Goa in India, we again showed that lay counselors drawn from local communities could be trained to deliver psychosocial interventions for depression and anxiety, leading to 70% recovery rates, as compared to 50% in the comparison primary health centers. Now, if I had to draw together all these different experiments in task shifting, and there have, of course, been many other examples, and try and identify what are the key lessons we can learn that makes for a successful task shifting operation, I've coined this particular acronym, SUNDAR. What Sundar stands for in Hindi is attractive. It seems to me that there are 5 key lessons that I've shown on this slide that are critically important for effective task shifting. The first is that we need to simplify the message that we're using, stripping away all the jargon that medicine has invented around itself. We need to unpack complex healthcare interventions into smaller components that can be more easily transferred to less trained individuals. We need to deliver healthcare not in large institutions, but close to people's homes. And we need to deliver healthcare using whoever is available and affordable in our local communities. And importantly, we need to reallocate the few specialists who are available to perform roles such as capacity building and supervision. Now, for me, task shifting is an idea with truly global significance. Because even though it has arisen out of the situation of the lack of resources that you find in developing countries, I think it has a lot of significance for better resourced countries as well. Why is that? Well, in part because healthcare in the developed world, the healthcare costs in the developing world are rapidly spiraling out of control, and a huge chunk of those costs are human resource costs. But equally important is because healthcare has become so incredibly professionalized that has become very remote and removed from local communities. For me, what's truly sundar about the idea of task shifting, though, isn't that it simply makes healthcare more accessible and affordable, but that it is also fundamentally empowering. It empowers ordinary people to be more effective in caring for the health of others in their community, and in doing so, to become better guardians of their own health. Indeed, for me, task shifting is the ultimate example of the democratization of medical knowledge, and therefore, medical power. Just over 30 years ago, the nations of the world assembled in Alma-Ata and made this iconic declaration. Well, I think all of you can guess that 12 years on, we're still nowhere near that goal. Still, today, armed with that knowledge that ordinary people in the community can be trained and with sufficient supervision and support can deliver a range of healthcare interventions effectively, perhaps that promise is within reach now. Indeed, to implement the slogan of health for all, we will need to involve all in that particular journey. And in the case of mental health, in particular, we would need to involve people who are affected by mental illness and their caregivers. It is for this reason that some years ago, the Movement for Global Mental Health was founded as a sort of a virtual platform upon which professionals like myself and people affected by mental illness could stand together, shoulder to shoulder, and advocate for the rights of people with mental illness to receive the care that we know can transform their lives and to live a life with dignity. And in closing, when you have a moment of peace or quiet in these very busy few days, or perhaps afterwards, spare a thought for that person you thought about who has a mental illness, or persons that you thought about who have mental illness, and dare to care for them. Thank you.
So let's appraise the evidence. We know that co-located models are associated with significant reductions in depression, anxiety, and bipolar disorder. My research suggests that when you train peers to deliver these the C intervention, so the screening, education, and empowerment intervention, that it was feasible for peers to administer it. They were able to administer it as part of their normal functioning within that setting, which is a concern because you're adding on responsibilities, and also peers are not mental health professionals. So part of the difficulty is integrating these models and having the peer set boundaries that they're not diagnosing practitioners. And using mental health language in a way that says, well, you know, you may have depression, let's move you to an evaluation so we can find out for sure. So they were feasible, as well as caregivers who participated in the study found that it was acceptable for the peer to ask about their mental health. So they were satisfied with that, which again is, we didn't know how that was going to go. Caregivers might have been like, why are you asking about me? This is about my child. But we also know there are significant draws and difficulties in implementation of co-located models. We know that they can be burdensome in terms of time and staff. When I had participated in that study at the 4 OB-GYN clinics, I was literally being shuffled from exam room to exam room because there was no space for me to administer a screening. And that's a significant issue. If there's no space, if there's no fiscal support, if there's no support for training, if you don't know where you're going to refer these individuals because the mental health service system is also fractured, then you run into huge barriers in administration. So I just mentioned some of the evidence regarding the model that I studied. A recent study that we are in the works in publishing found that caregivers who were involved in the child welfare system, who received this intervention from a peer, exhibited significant reductions in depression over time and engagement in treatment. So those were fairly, very promising findings. However, none of these studies were, on my model, were randomized controlled trials. They were small samples. There's a lot of noise in this data, meaning that there could be other reasons why those folks improved. But it does offer preliminary support for using a lay workforce or a non-mental health workforce to detect and treat mental health problems, or refer rather. There's also possible ethical issues involving alternative providers. So while we are addressing workforce shortages, if you involve members of your community in the administration of a mental health intervention or a detection and screening, there have to be safeguards in place to protect the privacy and the confidentiality of the information that those participants, who are your community, they're members of your community who you might run across in a supermarket or in another setting. So those safeguards need to be implemented to ensure that there's a confidential procedure in place. So let's also talk about the need for translational research. There's fairly strong outcomes associated with co-located models. However, the cost effectiveness of them is unclear. If it turns out that they are much more costly, it may de-incentivize individuals and organizations from implementing this approach because they may not be fiscally viable. Regarding the use of lay community workers and other personnel who are non-mental health professionals in the detection and outreach efforts, that too is burdened by a lack of rigorous research. So more randomized controlled trials need to be done to really discern the true benefits of these approaches. Also, there's a need for translational research regarding the pathway to care. So even if we provide a warm handoff or we walk that person to the 5th floor where there's a mental health clinic, there are still considerable problems with the mental health service system that are going to present challenges in access for many. Here too, in addition, we need to standardize the qualifications and the criteria by which we assign alternative mental health professionals to these important roles. Addition, if you look at the peer literature, which I'm fairly versed in regarding the child mental health service system, more research is really needed to tease out whether there are unique benefits of employing a non-mental health professional in this role. So anecdotally, we know that caregivers say, yes, I saw the peer as trustworthy, genuine. They helped destigmatize mental health. They had walked in my shoes. So those are common phrases you'll hear, but we really need to put the evidence behind it. We also need to be looking at those implementation and organizational factors that can impede or facilitate uptake simultaneously or concurrently. So looking at hybrid models and utilizing them to study both outcomes as well as the factors that prohibit or facilitate adoption of these innovative approaches and dissemination across settings. Okay, that concludes our module. Next meeting will be on finishing up the student presentations on ethical issues and dilemmas in practice.